Good afternoon. My name is Linda Edelman. I'm an associate professor at the University of Utah College of Nursing, where I lead two HRSA-funded workforce development programs, the Utah Geriatric Education Consortium, a geriatric workforce enhancement program, and the Nurse Education Practice Quality and Retention Program. Through my research in these programs, my goal is to improve access to quality care for older adults, particularly those living in rural areas. I'm pleased to introduce our speakers for today. Today we have two members of our mid-career special interest group. Dr. Michelle Polfus is an associate professor at the University of Wisconsin-Milwaukee College of Nursing and holds a position of joint research chair in the nursing of children between the University of Wisconsin-Milwaukee and Children's Hospital of Wisconsin. Michelle has clinical experience working with children and families as both a nurse and a pediatric nurse practitioner. Her research focus is on childhood obesity with a special emphasis on children with special needs and the role of the family. She is currently working on two funded studies through the NIH and ICHD. One is body composition and energy expenditure in youth with spina bifida, and the other is energy expenditure and weight-related behaviors in youth with Down syndrome. Our second presenter today is Dr. Susan Westmiller. She is an associate professor at the University of Pittsburgh School of Nursing in Pittsburgh, Pennsylvania, where she obtained her BSN, her MSN, and her PhD in nursing. She currently teaches both undergraduate and graduate genomics courses. Dr. Westmiller's program of research focuses on genetic predictors of treatment-induced symptoms in women with breast cancer, with a special focus on treatment-induced nausea and vomiting. She is the principal investigator for a National Institute of Nursing Research funded project and is currently conducting an NINR-funded addendum study focused on the influence of the COVID pandemic on longitudinal studies focused on symptom science. She is the current president for the International Society of Nurses and Genetics. She is also an active member of the Oncology Nurses Society, serving on the Research Priorities Task Force as a grants reviewer and a member of the CINV's Symptoms Intervention Team. Dr. Westmiller was recently inducted as a fellow in the American Academy of Nursing. Next slide, please. The goal for this webinar is to facilitate dialogue during our hour together and afterwards. The COVID-19 pandemic has impacted all of us. So our program will start with Michelle and Susan sharing their exemplars of the pandemic's impact on their research. If you have general questions about the impact, please share those questions in chat. We do not have time to answer research-specific questions. However, both Michelle and Susan will share their email addresses so you can reach them after the webinar. Then we will go into breakout rooms to share your challenges, solutions, and what will be incorporated into your research in the future. Before we get started though, I want to share benefits of being a CANS member. This slide shows the tangible benefits: a subscription to Nursing Outlook, discounted registration fees for the CANS Advanced Methods in State of Science Conference, and many other opportunities. For me, though, the membership is more than that. I've been a CANS member for a number of years, and I appreciate access to all of those things. But what I really appreciate is the networking opportunities through groups like this. I discovered this group in the past year, and it has provided me with amazing networking opportunities. I wish that I had gotten involved much earlier in my career, so I encourage you to do so. We go to the next slide. So what is the Mid-Career Special Interest Group? Our goals and objectives are to develop research collaborations among mid-career nurse scientists and the CANS research community, and to facilitate the exchange of peer support and enhance professional socialization among mid-career nurse scientists. And then finally, to provide opportunities for mid-career nurse scientists to promote and strengthen their existing leadership and scholarship. So who can be a member? Well, first you must be a member of CANS. Typical members are nurse scientists who use the rank of associate professor with or without tenure. However, we do acknowledge that this definition may not apply in all settings. For example, nurse scientists in the military. Okay, so we are happy to move on to our first speaker. Please welcome Michelle.
Hey, thank you, Linda, and thank you to CANS and the MidCareer SIG. I'm very excited to share my presentation, and I just want to provide a little more context about my research and COVID experience. So as noted, this was my first R01, the body composition and energy expenditure in youth with spina bifida. And it is a multi-site study, and the 4 data collection sites were specifically chosen because they represented 4 geographical regions of the United States, and that became very important as COVID hit. The 7-day protocol that we use, one crucial piece of this that is important to note is that on our first day, we do have our participants come to the hospital or the research setting for a 4.5 to 5 hour visit that is integral to the study. The timeline of our study, from July of 2019 to December, a lot of this was spent on preparation phase. Okay, so we were working as a single IRB, and we were also preparing by ordering and shipping equipment, translating and improving of our materials. Then in January and February 2020, this was really planned out, and we were so detail oriented about this, but the lead study coordinator and myself had planned to go to each of our 4 sites to do a 2-day, very detailed training session for them with our plans that in March we would start data collection. And as we all know, in March, we did not start data collection. COVID hit and things were halted. So I'm going to talk about my challenges in 4 different categories, and the first being research team, and I'll come back to each of these with strategies and what we've learned. So from a research team perspective, training has been impacted of our staff. Staff has turned over, and then we've also had extended time between the training and data collection, which has caused challenges for our study. From a hospital perspective, each of our 4 sites is associated with a pediatric hospital. So each of those hospitals all had different responses due to COVID or to COVID, and based on their state and their governors and their institutional policies. Non-emergent research was halted at different times and for different lengths of time. There was a geographical variation due to response to COVID as it hit different areas of the United States differently. We had times where we couldn't have individuals cross borders from Milwaukee or from Wisconsin to Illinois. That created problems. And even when non-emergent research was gone and we were able to start, just because it was open didn't mean that everything just became back to normal. Visitation policies have truly impacted our study. Limitations are still going on where at times in pediatric hospitals, only 1 family member is allowed to be with the child at a visit, which definitely impacted our ability to recruit as we do most of our recruitment during our clinic visits. And then the inability for that person that is there, they may be rushed to be leaving the hospital. They might be having to get back to childcare, that the children that couldn't come to the visit with that child. And also just limitations about not wanting to make any decisions about research without talking to others in the family. And that has led us to be very reliant on our permission to contact forms and advertisements. And then in general, because we have always had really large support from our hospital staff and clinic staff, they've been very supportive of our research. We see firsthand the burnout and fatigue that they are going through as COVID continues to wax and wane. And then in general, the prioritization of research has just not been, it's not the highest priority. 4 different universities are associated with this study, as each of the sites are connected to an academic institution. And what we saw is that each university had a different response for different reasons. So that variability creates another layer of complexity. We've seen resources be restructured and the sharing of resources. So sometimes it's people doing more with less staff. Everything that's on our facilities page or that we use within research, such as business office and human resources, have been impacted in some manner. Staff have chosen to change jobs or left jobs for other reasons. We've had staff members who were very integral to our study, not as an investigator, but as a support person who was placed on furlough. And then policies, I just want to share one example that never ever did I consider, but it became very critical, that in January of 2019, when I would purchase a large batch of Visa gift cards to use for incentives, not recognizing that having a specific expiration date on those Visa gift cards would become very relevant when we were unable to use those gift cards for over a year. So the amount of time and manpower that it went talking to Visa, and I think it's important to note that Visa does not have a clause in there for pandemic and research. I will just share that. Challenge number 4 has been the individual and family. And I think each of us that work with human subjects in our studies, we're very in tune to our populations, and we're very respectful of our populations, seeing firsthand what they are going through with changes in their routine, jobs, school, working from home. It's really critical to understand why research is not an easy, something easy for them to commit to. Transportation and the responsibility of public transportation. This was very evident for our Los Angeles group, and noting how many of our participants relied on transportation and how COVID affected that. And then in general, risk versus benefit. I think we're all very cognizant of our participants and not wanting to create a burden for them with our research. And working with children with disabilities and families of children with disabilities, I think this is a very vulnerable population. I see families that are stressed, and it's really hard at times to ask them to do one more thing, to commit to research. So lessons that I learned from this and that we've taken for the research team, we had some different training materials in place, but now we have a lot more. We have PowerPoint tutorials, we have our study manual, we have one-on-one virtual sessions, we have refresher sessions. This has definitely improved our study, and it will improve my future studies doing this earlier on. The availability on myself and our lead study coordinator, knowing that the sites might need extra help, we are on call frequently. And then continuing our ongoing research team meetings. This was something that we never stopped doing during COVID, and I think it was really instrumental because it kept us cohesive as a team, which was very beneficial. From the hospital standpoint, one of the best pieces of advice, and this really covers all of the different sections, but a very wise mentor said, you are documenting what's going on a weekly basis because things were changing so rapidly. And I'll admit, I was naive in thinking that maybe this was a short-term issue, but thank goodness I listened. So having careful documentation, knowing each state and each governor making mandates or policy changes has been extremely helpful from an RPPR standpoint for our reports, and also from a PI standpoint to understand where exactly we are at. And then respecting that one size does not fit all. Knowing that one hospital's response or one university's response does not mean another one will react the same way has been illuminating, because I think growing up and working in one institution, you get siloed in your thinking. So being open to understanding that different areas, different regions, different institutions react differently. The university response, I think this has been, I have to flip this into an opportunity, and it's been really helpful for us to look at this, knowing that pre or post-COVID, which is probably a misnomer, but during COVID and what we're going to be doing from now on in our universities, COVID had a definite impact on infrastructure. And some of this will have an indirect impact on researchers. So having really candid discussions on what does a university need to do to continue to support research while infrastructure is changing post-COVID. And then sharing and being transparent about the problem solving that we're going through. All of my trials and tribulations will help someone else. So not working in a silo and sharing that with our other tenure track faculty and researchers so they can hopefully not go through the same issues. From an individual and family response, I don't think this is anything outside of the box for me to say, but really being open to thinking very widely. How can we recruit differently? Can we change our protocol? Is it possible? And recognizing the limitations of our sample and empathizing. When I talk to a family member and they say this is not going to work for us right now, I can really respect that they mean not right now. And if they ask us to get back to them in 6 months, we certainly will. So sometimes it's not the study that's having a problem. It's really just everything that's going on. And then the biggest piece that I've learned from this is being a newer researcher with NIH, They are very helpful, they're very respectful, and obviously we're not the only study going through this. So having constant contact with our program officer, working with NIH, being very transparent on our reports. We were offered a mid-project extension, which we did take, and so our year 2 became 18 months instead of 12 months. We will probably have a no-cost extension. Our budget and subawards have been quite crazy and chaotic, so working closely with our sites and our grant administrators have been very helpful. The last piece is a summary page here, talking about thinking forward and how any protocol I write from here on out will definitely have more thought put into it. For our study, we work with a single IRB, which is not always a cost issue, but when you work with a commercial IRB, this does have significant cost involved, so any amendments do become a budget issue. Having a strong team and knowing our resources, documenting, knowing contracts and policies, communicating with our funding agency. And the last one I would say is something I still remind myself of pretty much every day, but the old adage of how do you eat an elephant, and it's not all at once, it's one piece at a time. And I think trying to remind myself of that daily when this is a very overwhelming experience of trying to progress our 5-year study during COVID with all the changes going on. My last slide is just showing how lemonade was made out of lemons, and the time frame that we used post-COVID to initially when COVID hit in March of 2019, we worked forward, and in March of 21, we submitted a supplement that was funded. So we are now replicating our study in children with Down syndrome. And due to learning lessons and pivoting, we've made some very crucial changes. So one of the changes is that we are doing this as a national study, but we have one single coordinating site. And instead of having any data collection within a hospital or research setting, everything is done virtually in the home environment. So our protocol is still intact, but there are major changes that will hopefully facilitate our ability to complete the study successfully. So that is the end. And I know this was a whirlwind, but I am very excited that I get to turn this over to hear our experiences from Susan Westmiller. Thank you.
Can you all see that okay?
We can.
Okay, thank you, Linda. And thank you, Michelle, for getting us started. My name is Sue Westmiller, as Linda told you, and I'm from the University of Pittsburgh. And it is a pleasure to be here today to share our story and how we pivoted, that seems to be the word that we're using these days, to make our study or to survive the pandemic. So in 2020, when this all began, we were in the middle of a longitudinal study called the Genomic Underpinnings of Treatment-Induced Nausea and Vomiting in Breast Cancer. It is a 1-year study, and we were on the way to, in middle of recruitment. We had some individuals that had already completed the study, but we were still recruiting. This study has at least 15 unique time points across a 1-year trajectory. We're focused on symptoms, and we use the PROMIS 29 and the PROMIS GI to measure the variables that you see here, with a special attention to nausea and vomiting. But we also look at physical function, anxiety, depressive symptoms, fatigue, sleep, pain, and ability to participate in social activities. So we were moving forward. the COVID-19 hit. And the significance of the pandemic on a longitudinal study we found was really complex, especially a study that was focused on understanding high symptom burden. So if we didn't account for the presence of coronavirus, we would really be introducing a historical bias to our study. So we felt that it was important to understand social and behavioral changes that have occurred due to the emergence of the pandemic, and not that are, what symptoms are from the pandemic, what symptoms are from the breast cancer that women have experienced and the treatment. And then we also were a little bit worried about study recruitment. So we had two major issues. How do we know if our data truly reflect the purpose of our study? And then how do we continue to recruit study participants to maintain recruitment goals? So one of the first things that happened to us in the spring of 2020, it's almost hard to believe it's almost 2 years ago now, I can't say last spring, that we started noticing some wonky changes on the PROMIS 29 after the COVID-19. And this slide demonstrates women that were 3 months post-surgery in January 20, and April 20. And we found that we saw a decrease in women that reported that they never felt hopeless. We found a decrease in women that were reporting refreshing sleep, an increase in fatigue, and a decrease in social activities. And this is just a few of the observations that we saw. But they were enough for us to start to wonder, how do we asterisk this data? So we had the opportunity, working with our program officer at the NINR, to also make lemonade out of lemons, like Michelle said, to get write for and be awarded an NINR addendum to our R01 to determine the effect of COVID-19 on the symptom trajectory experienced by women with breast cancer in their first 2 years of survivorship. And then to continue to try to identify the women at highest risk for increased symptom burden. We added extra variables so that we could try to really pinpoint what was happening to our study participants. We added the Corona Anxiety Scale. We had not ever included resilience in our data collection. We added living arrangements. Did it make a difference if women lived alone versus had the support of family members around them? We looked at household job or income loss, vaccination status a little later, and we also added the area deprivation index, which is measured by street address. That gives a sense of deprivation as far as financial, housing, access to food. So we are still in the data collection for our addendum study, and we will continue. But we found that of our 127 ladies women that we had, that we were able to have pre and post COVID, we've been following them very closely. 17 report they've not been vaccinated and don't want to be vaccinated. Since October 2020, we have 49 participants that have reported household job or income loss, which is 38%. And then we're finding from the Corona Anxiety Scale, some of those symptoms that they report as what they feel is more related to COVID. And they're a little different from the symptoms that we have seen, but trouble falling or staying asleep, feeling dizzy, sometimes just feeling frozen or paralyzed from the coronavirus. We have tons of qualitative comments, but we have women that have said COVID has added an extreme amount of anxiety and worry to the anxiety of having breast cancer. It's been extremely difficult trying to deal with both. But then we've also had comments like, I have been the most frightened yet this week as COVID cases spike in Westmoreland County. And this came from one of our study participants last December. And it was like an aha moment for us because we were feeling, at least in Allegheny County, where Pittsburgh sits, that we were kind of plateauing with with our numbers. But when we looked at the areas around us, we realized that this qualitative comment was telling us we need to look at the geographical differences regarding spikes of cases. So, Allegheny County was much higher in April of 2020 versus Westmoreland County, which is where our study participant talked about. And you can see if you follow her sign by December, or her line or her county's line, that her numbers were increasing. And so it's added another just another layer of complexity to what we have to look at to make sure that we really understand the influence of the pandemic on symptoms. The second major issue is how do we continue to recruit study participants to maintain recruitment goals? In March 2020, all clinical research activities, very much like Michelle reported, at the University of Pittsburgh were suspended. We had recruited all the study participants in person prior to surgery. So we would go to the clinics, or we would meet women preoperatively and get their consent in person. We couldn't do that. So we had to shut down recruitment. So our team decided, and like Michelle's, we've stayed close. We continued our weekly team meetings, even though they were on Zoom. And we decided that if we couldn't recruit, then the one thing that we could do with this time is to make sure that we stay in touch with all our current participants so that we don't lose anyone. And we actually found that women were more willing to talk during the high points of the pandemic than ever before. And we did not lose one patient. I think some women that lived alone loved our weekly phone calls. So in March 2020, our sample size was 253. August 2020, research mandates were lifted by the university. However, the hospital said, sorry, we don't want you back in yet. We are, they were still very busy, and they did not want research nurses or research staff members in the clinic areas where we had previously recruited. So we worked through many scenarios trying to figure out with the nursing staff how we could collect the data, how we could keep things going. But recruitment was just not something they were willing to do, to add to their already busy schedules. They were willing to collect a saliva sample for us, or collect, the medication data, whether the symptoms, as far as postoperative nausea and vomiting, but they just were not willing to recruit. So we talked to our team, and the surgeons agreed to include the description of our study in their preoperative teaching materials. And I have to tell you, I felt so blessed at that point, because I really wasn't sure that was something they would take on for us. But they believed in the study and they wanted it to continue. So they had us work out a flyer that they could use in their preoperative teaching, and then we could follow. So we had to do an IRB modification that was quickly approved, that allowed for a phone consent, so that after the physicians introduced the study, we would call them and we would mail them a packet. But before we could do anything else, we needed that verbal consent, which we were allowed. And everything else has worked okay, actually better than okay. It's been great as we continued all the previous protocols with weekly phone calls. Some women like weekly phone calls, others choose to respond via Qualtrics survey via email. So I feel like this has been a whirlwind for me too, but I'm happy to tell you that today, December 3rd, I can say that we met our recruitment goals. We are now at 340. We're continuing to maintain low levels of attrition. We realize what the lessons we've learned is we really have to keep the entire team involved. And certainly I underestimated the physicians' willingness to be an active part of the team, and they are still doing that. And we are continuing to follow study participants in the addendum study. And now as this Omicron variant comes, we will just continue to track to see what happens. So thank you, and I look forward to our breakout.
Now it is time to go into our breakout rooms. And so each of you will be assigned to a breakout room. There is a moderator and a note taker already assigned. And there will be 3 questions that we will be challenged to discuss. We will come back at in about 15 minutes, and the note takers will share the key points, and hopefully we'll have a little time for more discussion at that time. Is back. Well, welcome back, everyone. I hope that it was, 15 minutes is always too short when we have something to talk about that we're passionate about. So I hope that you all had as great of discussions as that we had in our breakout room. So what we're going to do for the final minutes is that we are going to call on our note takers from each group to provide us with some key takeaways of your discussion. And I am going to first call on Annette. Can you share with what your group talked about?
Yeah, sure. So I'll talk first about the challenges and then some of the solutions that we discussed. So some of the challenges were similar to our speakers earlier. We talked about recruitment challenges and having to change locations for data collection because patients or subjects couldn't come to the university setting, so they needed to go from home or have data collection from home. We had researchers from both university and hospital settings, so we talked about hospital research really taking a backseat, obviously, to clinical practice with staff being furloughed or redeployed, and trying to concentrate and move research forward in terms of writing papers and being able to do that piece at least. In terms of other challenges, students who were involved with recruitment had delays. We had one trying to create videos for patients or subjects to learn how to collect hair samples, self-collection at home, where they had before come in to have that done as part of their data collection. Delays in lab settings that we had no control over. So as far as solutions and practices, I think there was a big theme with our group. There was a lot of discussion, but I think overall what we were hearing was it was so important to keep the teams connected. The communication piece, the connection really helped to keep people engaged. And it also had unintended consequences as well as just, helping to maybe reduce anxiety, keep getting ideas flowing for research and trying to come up with creative solutions on how to make changes to recruitment and make changes to some of the practices that were in place with the research protocols. And, I also mentioned within our group setting, I lead some regular writing groups at my university, and that really helped in terms of getting publications out. We actually increased our publication rate in some of our writing groups to get some of our research papers off during the pandemic. And again, the unintended consequences of that social connection. And I guess one more solution or good thing that came out of research during the pandemic was the ability to enlarge recruitment areas outside of our home environment. So I think that was sort of broadly what we covered in our group.
Thank you so much. Can we move on to room 2 and Yvonne?
Okay, I'm unmuted. Okay, out of our group, and Wendy, I'm gonna ask you to help me stay focused. And so I don't know if you'll be able to unmute her if I don't cover it all. Wendy was the note taker and I'm the reporter. And so, yes, we came up with challenges around supply chain, recruitment, and how the need to pivot. We also saw there were some opportunities to NINR had some no-cost extensions that people were able to take advantage of, which really did help for those who had funded projects. We also noticed that it was some stress for team members, and we acknowledged the fact that there was certainly a burden in the healthcare system that that slowed turnaround for some folk. I think we also mentioned that networking as part of a solution, pivoting and trying to rethink perhaps the research idea. People definitely had to do IRB revisions, but taking extensions was part of the solutions that we came up with. And so I'll say, Wendy, did I capture some of what we talked about? You can nod if your mic is not open.
Yes, absolutely. And I think the opportunity to take the time to think differently because you had to. And, realizing the strength of the nursing community and the depth and breadth that we have, but also, thinking differently, I think is great. Thank you so much.
Thank you. Room 3, Austin.
Thanks, Linda. So I just want to go over a couple of ours. I think they've been repeated and I heard it from our speakers, but one of ours was the impact on recruitment. So one of our studies had a large older adult population that they were having trouble recruiting during the pandemic. Obviously, they're a vulnerable population. And so they had some flexibility with enrollment via phone. So that was a solution that they took forward. Others had were pulled in many directions. So they were focusing on the COVID front while also trying to do their research. So just having to be adaptable and flexible in every way to kind of combat the pandemic at the same time as conducting your research, as well as time, kind of in a similar vein. If you're constantly doing things for the COVID pandemic, then you don't have enough time to focus on your research. So that was another challenges. And then one very specific challenge was that one of our participants had a large data set that they needed to analyze, and the data extractors for that they were going to use were pulled to focus on the COVID data. So it was hard to find people to analyze that data. So they had to constantly reach out for no cost extensions and had really no control over the situation, which is what we heard from I think a NETS breakout room as well. So some of our solutions, and I think I've heard this before, is just be patient with yourself and with others and with life. You really can't control these things. We're in unprecedented times, which I'm sure we all heard before, and to be caring. So caring and appreciative of the people who are enrolling in your studies and taking the time to really be a part of this important project, and be patient and flexible and focus on the team. So those are just some of our brief notes. Feel free, Linda, to add anything that I missed.
No, I think you captured it wonderfully. Thank you. Room 4 is Lauren.
Thank you. Hi, everyone. I'm Lauren, and I was in group 4, and Joaquin Voss was our facilitator. So we identified a few challenges, but honestly, I think our group really focused much more on kind of the solution side of things, but I'll just run through quickly. So some of the challenges that the group talked about was the fact that access to patient data was a little bit trickier, just didn't have as great of access. So they thought of some unique ways to access patient data that hadn't been done previously, and thankfully their study wasn't interrupted. One individual identified that the launch of their study was delayed, but to kind of make sure that they kept in touch with the study participants, sent greeting cards, birthday cards, to make sure to keep that line of communication open. Another individual said that actually one of the things that they looked at during COVID was nurse well-being. And after doing an extensive literature review, realized that there really wasn't a singular definition for it. So they and their team did come up with a definition, and we'll be looking to publish that soon. And then the other challenge was just making sure that you were being compliant with the regulations of your institutions during COVID-19. And one person noted that how important it was to make sure that you classify your staff as essential staff so that they can make sure that they can continue to do their work. So in terms of solutions, again, thinking creatively about maintaining communication and contact with study participants, and overwhelmingly noted that doing interventions over Zoom or some other type of telecommunication platform really seems to be not only efficient, but also a way to connect with patients and study participants in a way that they also enjoy. So they may be more willing to participate versus having to come in face to face. So kind of tying a bow on things, leading into the question of what practices do you plan to continue moving forward? Really broadly speaking, thinking that the conversion to remote interactions creates not only efficiency, but also more engagement with study participants. But I'll stop there and see if anyone else from the group or Joaquin, if I missed anything.
Thank you, Lauren. And then last but not least, group 5, Aknil.
Hi, thank you. I'm going to add on to it. We had a very great discussion. One of the points was made was that prior to COVID, there was a lot of work happening with student teams where people were getting together and be able to talk through things quickly. And when COVID hit, of course, everything went online, and it really led to a loss of interactions and teamwork and learning together. And that has not been recovered. The work is happening, but slightly in a different fashion. And has slowed down the learning a little bit because you missed the connection. Another point that was made was that the studies that occurred in the health systems or in hospitals were shut down. And some of these studies have now been shut down for a full 2 years. And yes, it's unfortunate. And the nurses may be very interested in participating, but they're fatigued. They can just not handle it to adding on a study. So that really is a resource issue more than almost in a pandemic, which it's of course related. There was also the point made that people are trying to continue working through IRBs. There are DNP projects that are coming out of the health system. They get stuck in IRB, they need to be revisited, and projects are on hold, and that causes a lot of problems because some of these studies are also used for other research areas again. One solution that came up was that thinking that you would want to have patients in the clinic complete the materials. Turned out there was not enough time for that, but that the patients were very willing to complete the materials if you sent them paper and pencil. And so there was a shift made to go back to paper and pencil, mail, to get the surveys and to get the information coming in. So the patients, what we heard earlier, and the participants are very interested in participating and are willing to take the hurdles with us if we're staying engaged. Thank you.
Thank you so much. And we have used up all of our time. I hope that this has given us all an opportunity to share. What I'm hearing is that we're sharing a lot of good things, that we've had struggles, but we're resilient and we've come through this and we've learned things, and some of the things we're going to keep with us. So I hope that we continue to one, move through this COVID pandemic, but also continue to remain resilient and with strong teams and strong research programs. I just want to thank you for attending today. Thank you especially to Michelle and Susan for sharing, and also the CAN staff who kept us organized and on time. And if you aren't already a CANS member, please consider doing so, especially so you can join us at our next meeting. The MidCareer SIG's next meeting is January 20th, I believe, at 2 to 3 p.m. Eastern Time. And happy holidays, and see you in 2022.